Hello, everybody. Welcome back to my channel. This is me, the coding coach, Marciana Jones. Thank you so much for joining my channel. Thank you so much for all of the support that you guys give me on YouTube, on Instagram, on Facebook, and my emails, on the 800 number. So I just want to thank you so much for all of the support. Don't forget to like, comment, subscribe, and share this video with your coder friends if you care. So today I want to talk about like the disconnect between physicians and coders sometimes. Just like the example that I always like to give is, if you know me personally, I am so fascinated with Hispanic culture. But that's one of the examples that I always give. I have a lot of Hispanic friends. They're from, different Latin countries. They're from Colombia. There are some from Brazil, but all of them speak Spanish. So the thing is, it's a different dialect, but it's the same language. So that's what I pretty much want to talk about today, being a different dialect with the same language. So this is pretty much bridging the gap between providers and medical coding guidelines. And this is the gift of revenue because this also helps drive the revenue for the physician. And it also helps you to be a better medical coder. So let's talk about history of. So before I even get to reading the slides, when I speak of history of as a coder, when we speak of history of, that language to us means that that condition, that disease, or whatever it is, it's no longer there. It's history. It's not being treated anymore by medications. There's no therapy for it. There's no anything. It's a history and it is over. However, clinicians may write in their medical records, medical charts, or documentation that the patient may have a history of diabetes, a history of hypertension, history of cancer. And these things may be still present, but they usually list it under the history of as saying this is the history of the patient's conditions. So we have to bridge that gap in making sure that we're on the same page. So I'll read the slides. When providers document history of within a medical record, they're typically mentioning or listing either past medical history or current coexisting conditions. Example, patient has a history of diabetes type 2 and is currently on insulin for disease control. Well, the provider says a history of diabetes, and our mind will think, oh, they no longer have diabetes. But however, when they continue to say that the patient is currently on insulin for control, that allows us to understand and know that this is a current condition. The previous statement is reflective of the patient currently having diabetes type 2. Although the provider may have documented history of, the current prescription of insulin reflects the disease is still present. So I'll let you look at this slide for a second and kind of take this in. Okay, so let's move to the next slide. Let's move into some examples. So coders language per ICD-10 guidelines, coders are taught that history of reflects the disease is no longer present or being medically treated. So examples, breaking through the language barrier. So CVA, stroke, and residual deficits. So I definitely wanted to do another video on this, although I have one previously recorded. I want to do another video on this because I know a lot of people who are starting Optum, which is United Health Group, starting their CRC jobs with them. And this is one thing you're going to have to thoroughly understand when you're coding for risk adjustment is the history of, and also CVAs and strokes, very important, because it's something you'll often see a lot in risk adjustment coding. So the code I63.9, which is cerebral infarction, pretty much a stroke. You know how you can say physician or doctor. You can say lawyer or attorney. You can say teacher or educator. You can say cerebral infarction or stroke. So the code I63.9, cerebral infarction unspecified, should not be used in an outpatient setting unless the patient is actively having a stroke or a CVA. Think about it. Who will come into an outpatient setting for a new patient appointment or a follow-up appointment if they're actively having a stroke? Nobody. They will go to the ER, urgent care, or somewhere like that. So when patients are documented as having a cerebral infarction, which is I-63.9, many providers list the condition as history of stroke, which is not always the most appropriate documentation practices due to other extenuating factors. So, which basically means in a nutshell, it may not be a true history of a stroke. It may need another code. Inaccurate documentation leads to inaccurate application of medical codes, and it will definitely affect the revenue as it pertains to risk adjustment and coding. So, CVA, stroke, and residual deficits. As a coder, when we use history of stroke or TIA, that's going to be code Z86.73. Now, this reflects the patient previously had a CVA or stroke or a TIA, but does not have any residual of deficits. So this is what we mean, or this is what I mean when with no residual deficits, and I'll let you know when to use the code Z86.73. So if a person has had a stroke, whether it was last week, last month, last year, 10 years ago, whatever the case. So if a person has had a stroke and they have no deficits, which means that you can't tell that they've had a stroke. You know, most of the time when people have a stroke, their one side of their body kind of droops or their face is drooping. They may have swallowing problems, or there's a lot of different problems that you would have as an effect or due to having a stroke. However, if a patient has had a stroke and there's nothing, absolutely nothing wrong with them, then you're going to use the Z86.73, which history of a stroke, which is saying this patient has a history of it, but it's no longer being treated. We can't even tell it's still there, so it is a true history. Now, if there are residual deficits from the stroke, such as hemiparesis, which is pretty much paralyzed on one side, you have memory deficits, psychomotor dysfunctions, or etc., whatever, we will code from the category I-69.3, which is unspecified sequela of the cerebral infarction. So anything that happens to you as a result of the stroke, there's a code for it, and it's going to come from I-69.3. And I'll give examples so you can understand what I'm talking about. As we specify the sequela effect, like I said, there is a specific code that is parallel to the documented condition. So here are some examples, and I can show you what I mean by missed revenue. So a 48-year-old female patient presents to the ER after her family found her unresponsive in her bedroom. The patient has right-sided hemiparesis, and there is a history of malignant neoplasm of the central portion of her left breast. She is currently undergoing chemotherapy treatments. After further evaluation and testing, the provider determined the hemiparesis is caused by cerebral infarction. So as you read that, I'll go over the codes and tell you what the right codes are, and then we'll go and show you how it could be coded and it would be wrong. So I-63.9 is a cerebral infarction. So this person has actively had a stroke. So this person has actively had a stroke. So when they have actively had a stroke, then you're going to use the I-63.9 code, which is an HCC code. So, and then we see that the patient had left-sided hemiparesis due to the stroke. So remember when I said we will come from the category I-69.3 if a person had a sequela, and we know sequela means late effect. So if a person had a deficit or something happened to them due to the stroke, then we're going to come out of category I-69.3. So this particular one is I-69.351, which is also an ICD-10 code. So also in this example, we see that the patient is currently undergoing chemotherapy for their history of neoplasm, history of breast cancer. So when we think about history of cancer as a coder, you're basically telling us that this person has a history, but they no longer have cancer anymore. However, there's a direct conflict in the documentation because I can see from this example that she is currently undergoing chemotherapy, which means there are still ongoing treatments. So we would not use the history of breast cancer code. We will use the active breast cancer code that reflects the left breast cancer, the central portion, which is C50.111, which is also a HCC code. So let's read it again. The same exact example, but on this time, these codes are wrong. But let me tell you how they can look right and appear to be right. And that's why risk adjustment coding is so different. It's important to learn and to know if you're going to be a risk adjustment coder. So I'll read it again. 48-year-old female patient presents to the ER after her family found her unresponsive in her bedroom. The patient has right-sided hemiparesis and there is a history of malignant neoplasm of the central portion of the left breast. She is undergoing chemotherapy treatments. After further evaluation and testing, the provider determined the patient has hemiparesis due to a cerebral infarction. So I63.9, so they have that code right because they had a cerebral infarction. So most providers or coder will select that, especially in an inpatient or, an ER or urgent care setting where you're actively having a stroke. So I63.9, actively having a stroke, we will use that. So check out the other code. Grab your ICD-10 book if you need to. So I want you to look up this code, which is G as in girl, 81.91. Grab your ICD-10 book. So if you grabbed your ICD-10 book, and if you're looking up this code, Z81.91, you see this is hemiplegia, which is the same thing, hemiparesis, hemiplegia, unspecified, affecting right dominant side. So we did say that this patient had hemiparesis or, hemiplegia. It's kind of the same thing, like attorney, doctor, and it affected their right side. So on this wrong code, we have G81.91, which is hemiplegia, hemiparesis, unspecified, affecting the right side. This code is wrong. Although it reflects hemiplegia, this code says hemiplegia unspecified. That's why it's wrong. We know from the first example that this hemiplegia is caused due to the stroke. So it's not unspecified. It's specified saying due to the stroke or caused by the stroke. So this G8191 will be absolutely incorrect. It's hemiplegia or hemiparesis for your right side, but it's not because of the stroke. Remember, anytime you have a stroke and there's something wrong, you're going to come out of I69.3 category. So the last code that I have here is Z85.3, which is personal history of breast cancer. So some people will read the documentation and where it says patient has a history of malignant neoplasm of the breast, and they will just automatically think, oh, okay, history of breast cancer. Let me find the history of cancer, breast cancer code. And wrong. It's not a true history, although the provider wrote history. It's not a true history because the patient's still undergoing chemotherapy treatments. So if they're still undergoing treatments, that means that the disease is still there and it's not a true history of. So let's recap. If the patient previously had a stroke and they don't have any residual deficits present, then you're going to use Z86.73, which reflects the patient has a history of stroke, meaning they are no longer being treated for the condition and there are no signs that the condition still exists. If the patient previously had a stroke and is experiencing hemiplegia or hemiparesis affecting the right dominant side, we will use the code I69.351. It would not document the condition as history of because the current residual deficits require medical attention and or treatment. So I hope this was a great recap for you, especially for cerebral infarction or strokes. This is great information to know, especially going into a new risk adjustment job, if you're going into a risk adjustment course, or if you're just learning more about risk adjustment coding. So this is very imperative information for you. Also, the risk adjustment course is coming up 11 weeks, you guys. It's only 11 weeks. If you've been thinking about coding, you've been wanting to do it for a while, something has been holding you back, I've made this course super, super affordable. I know when I was going through my coding course many years ago, I spent about $4,500 including courses and books and exams. So I know how that can be. And I had 2 children. So I know how that can be. That's one of the reasons why I wanted to make this course super affordable. So the course is only 11 weeks from April the 16th through June the 25th, which means when you complete the course, you'll be ready to sit for your CRC, which is Certified Risk Adjustment Coder exam. Once you sit for your exam, I would recommend, if you finish the class on June 25th, I would recommend taking the exam sometime in mid-July, end of July, bam, you're certified in just 11 to 12, 13 weeks from taking the course and preparing for the test and going ahead and taking it and passing it. So I will drop the link below if you're interested in taking the class. $750 total. There are 2 payment options. You can pay in full, or you can pay $250 a month for 3 months. You'll also have 12 months access for the material. So even if life happens and something goes on, you will have 12 months to access and view and prepare for this material. However, if you stick to the schedule, you'll start on April 16th, you'll be done on June the 25th. Everything is self-paced. However, I am also offering 3 live virtual sessions with the course. I didn't want to just throw anybody out there and say, here's the course, it's self-paced, go at it. I wanted to be able to explain each and every chapter for those who may not be already a coder. So my class is user-friendly to the aspect of you don't have to have medical healthcare experience to do this class. I am basically starting from scratch and teaching every single thing that you would know or you would need to know to pass the CRC exam. So if you're interested in more information, you can, of course, email me at Allied Health Prep Academy at gmail.com. I'll link that below in this description box as well. You can also find me on IG, which is the coding coach _CPC. And you can find me on YouTube as the coding coach CRC CPC, because I have both of those certifications. The 1-800 number, if you need more information and you would like to speak to me about the information, is going to be 800-977-1550. April the 10th is going to be the last day for registration. So if you need more information, don't be afraid or don't hesitate to reach out. And also for people who are interested in coding, and even if you take another class from somebody else, I still want to make sure that you have the right information before you sign up. Don't hesitate to drop a comment under one of these videos. If you're looking into a specific coding school, you want to make sure this is the right certification or whatever it is. I care enough about my coding community to make sure that I am delivering the most accurate information, whether they take the class from me or not. That's the least of my worries. I just want to make sure everybody who's in tune to this channel, level up in their coding career and just have as much information as possible to just make informed decisions about their next step or next steps. So thank you so much for joining me, the coding coach, today. I really, really appreciate it. Earlier, as I mentioned, don't forget to like, comment, and subscribe. And thank you again so much for your support.